Good afternoon, everybody, and thank you for joining us again for another one of our free MAG educational sessions. Today, we have the very lovely Associate Professor Katherine Brown with us. Katherine is a sexual health and forensic physician. So that means she deals with all things to do with our sexual health, including sexually transmitted diseases such as HIV and others. But she also works in the area of sexual assault forensic examinations. And that's probably one of the main reasons why this seminar would be of interest to you in the legal and personal injury space. This seminar has some confronting concepts, so be aware of that, be mindful of that. If you have any questions at the end of the seminar, there will be a time for you to ask those questions. But if you have to go before it's finished, please type your questions into the chat and I'll make sure that they get answered. If you could keep yourself on mute throughout the presentation and then only unmute yourself to ask questions so that any sound from your home or office doesn't interfere with the quality of the recording. So Dr. Brown, Associate Professor Brown, has worked with us for some time and she has provided some outstanding reports for our clients in matters of sexual violence predominantly. Her knowledge is highly renowned and she's well respected in her industry. She's also involved with university level teaching for medical students in this area. We are very proud to have her on the MAG panel. If you have a matter that you would like to book with Associate Professor Brown, please contact our team at admin@medicolegalassessmentsgroup.com.au and we will help you with that. Without further ado, I hand over to you, Katherine. Thank you so much for giving of your time and your expertise to us today.
Thank you very much, Michelle. So as Michelle mentioned, this is about strangulation in domestic and family violence, but we actually find in sexual contacts now, there's more people thinking that strangulation is a normal event and that strangulation should be or could be part of a regular safe sexual encounter. And I think we really need to take it very seriously. There is no such thing as safe strangulation. And I hope that at the end of the talk, you'll have a bit more understanding of what's happening. So hoping this will go to the next slide. So what I'm hoping that we'll be able to do at the end of the session, that you'll have a little bit of an understanding of the signs and symptoms that a person who's been a victim of non-fatal strangulation might exhibit, and be able to have a bit of discussion about the implications of non-fatal strangulation. As Michelle mentioned, this presentation includes graphic language and some pictures. None of the pictures are of individuals with whom I've had dealings. They're stock standard photographic exhibitions, and I'll explain as I go. So why is it important for you to have an understanding of non-fatal strangulation? I think it's often overlooked, and so patients and doctors are not aware that there may be no signs of injury. So around about half of the people who've died in a number of studies with quite large numbers of people had absolutely no neck injury to be seen. There's an assumption people have that you'll see a lot of damage to the neck if somebody has died. So obviously, if they haven't died, it's equally possible that there may be significant internal injury without there being any external signs of that having occurred. In the setting of domestic and family violence, it's associated with a greater incidence of lethality, so that we know that future homicide risk is increased by people adding strangulation and by adding sexual assault to a domestic and family violence setting. So it's something to be aware of if you have people coming to see you. And obviously, when you're already in a medical legal space, people might be consulting you about certain things. But it's important, I think, in general, and I think we probably need to be looking at raising awareness in the community for the risks associated with non-fatal strangulation. It can be recurrent, so particularly in domestic and family settings, people have been strangled more than once, and the more times you're strangled, the greater the level of injury that's occurring to your brain. So your brain is losing brain cells every time you become hypoxic. There can be very significant long-term effects, and I'm going to mention some of those as we go on, of chronic brain injury associated with this. And of course, it can be upsetting to people to be strangled. So I want a few definitions first. Hypoxia means a deficiency, so not enough oxygen. Anoxia means there's no oxygen. going to the brain. And the brain is a very large and important organ that tells your whole body what to do. It tells you to breathe, it tells you to swallow, it tells you to stand up or lie down. So it's very important that your brain actually knows, has enough oxygen so that it can direct all the other parts of your body to do their regular function. Asphyxia is when the body is deprived of oxygen, and suffocation is a type of asphyxia. So if we look at further definitions, if we're talking about strangulation, that can be manual, so with a hand, from the Latin manus, and it's constriction of the tubes going down the neck. So you can see that the neck, the blood vessels are very close to the surface because the neck's not a very big organ and has very thin skin, as opposed to something like the palm of your hand or the soles of your feet where the skin's quite thick. So you can have manual strangulation, so that's with the hands. You can have a ligature, so something like a belt, or a cord of a blind, a scarf. So sometimes people have accidental strangulations, and it's one of the problems that occurs for babies, for instance, if they're left in places where there are blinds and cords and things hanging around, or a deliberate hanging, or where a person's actually suspended. Many people use the word choking interchangeably, but actually that's a different thing. Strangulation is pressure from the outside, choking is from the inside. So if you've ever swallowed something, got something into the trachea, and you've coughed and coughed and coughed, and presumably if you're still here, you've actually got rid of it. But you can sometimes get swallowed, you inhale something rather than swallowing it. So you have a piece of food, something happens, the piece of food goes down the wrong tube, and then somebody does the Heimlich maneuver, or whatever maneuver it happens to be at the time that's popular, and you get rid of whatever that piece of food was that was blocking the trachea. So what you want to have is that's patent. So your trachea needs to be able to put air in and expel the air out that's got rid of the oxygen, or has less oxygen. And smothering is depriving you of oxygen in other ways. So smothering is often like the pressure, say, from a pillow. People used to, you've probably read novels in the past maybe that where people were smothered. You'll have heard potentially of babies being smothered by parents with co-sleeping, where in some cultures it's quite common to co-sleep. But if you roll over as an adult on top of a baby, the baby can't move, wriggle out from under you, whereas another human can usually get out from under you. Oh, sorry, an adult can out. And so babies sometimes are smothered in co-sleeping situations. So what's the crime? In New South Wales, we have moved to actually define this as a crime. So it occurs often with a history of domestic and family violence, but we're noticing a lot more strangulation occurring as part of regular sexual encounters, not necessarily in encounters where people think that they wish to be violent towards their partner. The victims are predominantly women, and the person in a domestic and family violence setting in particular is somebody who wants power and control. It's not about sex, it's about power and control and being able to overpower someone and say, you can't do anything, I'm in charge. Manual strangulation can be one-handed, so an adult hand can put the pressure on the neck. An adult male can easily do that on a female or a child. It can be two-handed. And sometimes we can tell the difference, A, from the history, and B, from the way that if we do see injuries, we might see particular marks on the neck. Sometimes also people put an arm across and obstruct some part of the neck by using the arm. We know that there's an increased risk of homicide. It's something like 7 times as likely for a person to have an eventual homicide if they're being strangled. And men who strangle have demonstrated the capacity to kill. You have to be really up close and personal. If I happen to have a gun, which I've never shot a gun in my life, but if I happen to have a gun, I can stand a very long way away, and assuming I'm a good shot, I can actually kill you from a very great distance. I do not need to be up close and personal. To strangle someone, you have to be really prepared to know that you're going to kill someone, you're that close to them. In Australia, strangulation accounts for about 5% of homicides overall, but about 9% of homicides in a domestic and family violence setting. So it's more common in that setting. In New South Wales, the Crimes Act was changed a number of years ago, and it's Section 37 that makes the Crimes Act goes back to 1900, but they add little bits of information to it over the years, adding and subtracting different things. So Section 37 now says, in a longer form than this, that it's a crime to attempt to choke, suffocate or strangle, using all the different words people might use, or render a person unconscious or incapable of resistance. So that's deliberately undertaking that act. obviously, if somebody comes into your house and you've accidentally left the blind cord down and the person's young and strangles themselves, that's different. That's not an intentional matter. It might be neglect, but it's not an intentional matter like actually taking your hands out there and strangling. And it carries a sentence of up to 25 years. So it's recognised as being significant. In the New South Wales Violent Death Review information that's been available to us since 2010 under the New South Wales Coroners Act, strangulation was reported as the cause of death in 14.3% of 244 women killed by a domestic and family violence partner. And you compare that with less than 2% of male victims of domestic and family homicides. We don't have data that tells us about the number of previous events that have occurred. The only way we could ever, can do any research on any of that is to look at whether people have presented either to emergency departments or to sexual health services or sexual assault services, for instance, where they might have had a previous discussion about having been strangled by the person in question. 51% of female homicide is domestic and family related compared with violence against men. So men actually die more frequently from violent acts than women, but domestically, women are a much greater percentage of the victims. And you can see as well that Aboriginal people are really overrepresented. Aboriginal people, depending on what community we're in, may account for between 2.5% to 3%, obviously more in the Northern Territory, of the population. But in domestic and family violence victims, 16% of female victims of DFV are Aboriginal, and 35% of male victims are Aboriginal. The common age is that sort of 20s to 30s to 40s, so it obviously can occur younger and older than that, but the most common presentations are fairly typically in the sort of 25 to 45 age group. And if you look at manner of death all over, stabbing is common, so 33%, physical assault where somebody beats each other up, shooting 13%, and strangulation's 14%. So two quite violent ways of approaching other people that you can say, well, 4 ways there of approaching other people, and you can see how common strangulation. Most of us don't think of strangulation as being common, but in terms of the number of deaths that occur, yes, it is. So it's a very gendered crime. 85% of victims are women and 99% of perpetrators are male. Most commonly, as I mentioned, in people in their sort of 30s. It can be associated with sexual assault. So if you have a combination of domestic and family violence and sexual assault and strangulation, that's a really problematic situation. Strangulation by strangers is uncommon. So a stranger is more likely to stab you, might get into a fist fight with them, but really it's that personal thing where people come right up and strangle the person. There may be other blunt force trauma. The person may also suffer head injuries, and people who have been strangled are often threatened. They're threatened by the person who's strangling them. They often are quite fearful of their lives. They may have been told that, no, I want to kill you, or if you don't sit still, lie still, I will kill you. Victims often lie about the causes of their trauma because they're afraid that they're going to be exposed to further trauma, particularly if they have to go home to the same situation. And one of the unfortunate things, of course, is that some of the violence can be witnessed by children. And so it's always very important that we notify, that we ask the question about whether they're children, whether there are any children in the house, and that notifications are made. It's a mandatory notification setting because those children are at risk of harm. They may not be at risk of physical harm themselves, but they're at risk of emotional distress, psychological harm as a result of witnessing. Plus, they're, of course, at risk of not recognising that this behaviour is abnormal and potentially growing up to be more violent themselves. So how easy is it? Well, it's remarkably easy to actually cause harm to somebody by putting pressure on their neck. So the pressure needed to do the jugular veins, to compress the jugular veins, which come from the brain back down eventually into the heart, taking away the blood which has lost its oxygen, and the oxygen's been distributed to the brain. So that blood's not as good anymore as it was when it went up through the carotid arteries. So that requires about 2 kilos of pressure, so not a lot. 5 kilos to compress the carotid arteries, which are taking the nice fresh blood back to the brain. And the brain uses about 20% of your all of the blood in your whole body anytime. So one of the important things to know is that people rapidly become unconscious. There was a very problematic study done in the United States in 1944 by their Defence Force, where they employed a group of prisoners, offered incentives to be strangled, so voluntarily strangled, and they gave them a buzzer. They said, press the buzzer, and we'll stop when you can feel something happening. Nobody ever pressed the buzzer because they were unconscious before they got to the point of being able to go, oh, I'm feeling fuzzy, I'd better press the buzzer. Some things that can occur can be things like hematomas, that's like a blood clot that can rupture a long time after the event. You have carotid artery dissection, and we're going to talk about that later, which is where the arteries just sort of disintegrate. That's not a good idea because you actually want blood to go from here to there. If your artery is no longer functional, then it can't do that. And if something happens to your carotid arteries over a period of time, like a blockage when somebody gets older and a bit of clotting occurring, sometimes you can get parallel veins and arteries developing so that you still get some blood supply. But if something happens very rapidly, of course, there's no time for any reversal to occur. And brain death can occur very rapidly, so a few minutes. It's not something that takes a long time. A few minutes of sustained pressure, people can die. In comparison and to sort of work out what is it that you need in pressure, a male handshake, so an adult male, shake his hand, good strong handshake. Sometimes people want to impress you and they stay really extra hard. But a male handshake can give you 3 times the amount of pressure needed to actually kill someone with a strangulation event. Things like the trachea, yes, you can block the trachea, but that takes a lot more. It's generally a vascular event because it doesn't require that much pressure to cause a problem. And as I mentioned, 50% of people may have no injuries, and the injuries that people have might be quite minor that we see. So as I said, rapid loss of consciousness because the oxygen's not getting to the brain. So the brain goes, oh, okay, better lie down. Maybe that'll help the situation. That's one of the reasons we faint. If we're standing up and all the blood's pooling in our toes, then the body goes horizontal so that the brain is going to get more of the percentage of oxygen. But in this situation, of course, it's a blockage, and so the brain doesn't know that. People often have no memory of the event, and so sometimes it's difficult for someone asking a history. They say, well, what happened? I don't know what happened. So what we ask people to tell us is, what's the last thing you remember? I remember he was standing in the doorway and Johnny was behind him. One of the reasons people don't remember is you actually need oxygen in your brain to actually lay down a memory. So when we have memories, when people can't remember things, particularly if it's new things. So if you think about someone who's demented, people who are demented often have very problematic short-term memory. When they first are dementing, they can remember what happened to them when they were 5 or 20 or 40, but they can't remember what they ate for breakfast or whether they had breakfast. And it's because they've stopped being able to lay that memory in. And then if you lay the memory down in your brain, then you retrieve it. If you've never laid it in the first place, you can't retrieve it because it just isn't there. Same principle occurs, that if there's not enough oxygen going to your brain, to the right bits of your brain that actually lay the memory down, you then can't retrieve it. So we want to, from a time frame point of view, look at what do you remember, what's the last thing that you remember. Seizures can occur quite rapidly. We also ask people about, it's not as common as some of the other things. We also ask people about things like continence. People will become incontinent of urine within 15 seconds and of their bowel, maybe 30 seconds due to the hypoxia. So we quite often ask, did you have any problems with continence? We might ask police or say to police, check the location to see whether there's urine on the bed. And just yesterday, I was hearing a story of somebody who had presented and been examined, and the person who was doing the strangulation had actually told the woman, you need to put a sheet down under the bed to catch the wee. You need a sheet because you're going to wet the bed, which I just think is horrific in terms of he knows that he is going to cause her to become incontinent. So we're very pleased that she presented and that we can hopefully assist her with pursuing a case against this person who is deliberately strangling her and knows some of the consequences. People can suffer sort of fuzzy feeling. They may become unconscious. They can have changes in their voice and all sorts of other things occurring. And one of the things that happens if this happens repeatedly, and we do have people who are in relationships where every time they have sex, the partner strangles them because it excites the person. They can end up with brain swelling, and that causes them a lot of discomfort and damage to their brain and their neurological function. So there are lots of things that we might see. Some of them are to do with the eyes, so they're very visible if things are on your eyes. The person may experience things like flashing lights and tunnel vision, which means they can't see the periphery. Tunnel vision means you're just sort of seeing, as though you're looking down a tunnel, a bit of blurring. They may have a period of blindness. And these things might recover by the time we get to see them, but they can explain to us that they've experienced some of those symptoms. They might not be able to move their eyes properly, and that relates to there are 3 different nerves that cause your muscles around your eyes to tell your eyes to move left or right or up or down. And then we can see things sometimes like petechiae, which are tiny little bruises that occur as a result of rupture of the very small blood vessels called capillaries. So petechial hemorrhages occur when there's an increase in pressure. Now, they can occur for other reasons. People can have petechiae as a result of coughing and sneezing as well. But certainly with strangulation, they can occur. They can occur in the mouth. They can occur in the eyelids. They can occur over the top of the face. Sorry, in the face. They may have hemorrhages on the eyeball. So you're looking at the white of the eye and you see these red patches. Now, of course, subconjunctival hemorrhages can occur for a variety of reasons. They're not simply related to strangulation, but they're just one of the things that we may see on occasion. And we may not see all of those things immediately. We probably see petechiae fairly quickly, but we might not see the subconjunctival hemorrhages till the next day. Injuries to the neck. So we might see bruises. So we look at bruises, and when we're describing a bruise, we might describe it as a 1 centimetre purple bruise, and it might have a pattern. So there might be 2 or 3 bruises in a row. And on a report, we might indicate that this could be fingertip bruising. In line with the history that we've been given, and one of the explanations for it would be that. We might see abrasions, and abrasions on the neck can occur as a result of the person trying to claw away, as well as sometimes the person who's the perpetrator causing an abrasion. The neck may swell, and so sometimes, depending on the seriousness of the patient's problems, we might measure the neck. We would admit them. Our role is to examine people and take a history and document all of those things. But if they're really unwell, we're going to leave them in the ED and have them monitored until they're well and able to leave. But we might look at things like, we would ask them, have they had any change? We might hear it. Have they had any changes in their voice? So sometimes people have a really hoarse, husky kind of a voice. They might have pain when they're swallowing. And so we'll ask them about things like, is there any change in your voice? Now, some people have a hoarse, husky voice. It's just who they are. Those of you who are old enough will remember Neville Wran had an injury to his neck, having neck surgery, and had a somewhat different voice than what he had before the surgery. They may have a fracture in the cartilages in the neck, but that's not that common. It's more common when people are older because the hyoid bone is very fragile, very tiny little bone. In older people, your bones are thinner, so that's more likely perhaps to occur. And then sometimes people just can't talk properly. So the other thing they can have is trouble with the esophagus. So they might have problems with swallowing. They might drool. This baby is purely on this photograph for drooling. It's not a baby who's been strangled, but it's a nice drool. I don't know how somebody took a photograph of drool, but there they are. And those things relate to changes in the neurological function. And then they might have subcutaneous emphysema, which is like sort of air in the skin. So normally you put your hands on your neck, you just feel it's soft tissue. You don't feel like a little crepitus, as though there's air bubbling around under there. And they might have some pain on movement of the neck. Most of us, have had a bit of neck pain at different times from whatever reason, but we might have a story then for why they've got it. Then the other thing that people can have is respiratory symptoms. So that's your breathing. They may have shortness of breath, difficulty breathing, pain with breathing. They may have a different sound when they breathe, and that can be related to changes in the larynx. They may have aspirated something during the event. They can have, they're trying to breathe against the closure of the glottis. So there are lots of different things that can occur at a respiratory level. occasionally people will have cardiac injury. That's pretty uncommon. And they can have pressure over the carotid artery, causing an arrhythmia because the little nerve ganglion there. But that's a much less common thing than the vascular events that cause problems. Skin changes. So you can see, if you look at the top picture, I think it's on my right. I think it's on your right when you're looking at the screen. Ligature marks, so that could be a belt or a scarf or something that's put around the neck and then stretched so that it puts pressure on the neck. The one on the left in the second row, that you can see a very nice example of that sort of neck injury here, and then the blood is changing. So you've got compression, and then the blood can't go anywhere, so it's staying up there and causing that redness change. And you can see, I hope, some tiny little red, mini bruises, and that's petechial hemorrhaging occurring as a result of that pressure. This one on the right in the second row is typical bruising that can occur on the neck. If you think about, could that occur as a result of fingertip pressure? And then the one down the bottom, that sort of injury often occurs when people are actually trying to take a ligature or take a hand away. They're desperately scraping with their own fingernails to move the pressure so they can actually breathe again. So some injuries will be self-inflicted, but they are typical of a defense injury. Some of the other things that can occur that are reported, things like a thyroid storm, I've never actually seen that, but it's caused by a life-threatening excess of the thyroid hormone, causing tachycardia, which is very fast pulse rate, and a lot of other nasty things like delirium and cardiac failure. People can have headache associated with it, and that associated with the dissection of the artery. Sometimes people will be given aspirin to try and reduce some of the strokes that might occur. Tinnitus is that ringing in your ears. Now, people can get tinnitus for a variety of reasons. They can have bleeding from the ears if there was a lot of pressure. They can have a delay, as I mentioned, in strokes occurring. It's one of the common causes for young women having strokes. Miscarriage has been reported, and the memory problems with oxygen and with fear, so they're not setting them down. So one of the things that we want to know, we ask, how many times did it occur? We ask, has it ever happened before? We ask, over what time period was this particular event taking place? And what, was it one hand, two hands, ligature? What was the way that the strangulation occurred? Was there any way the person protected themselves? And that's not to blame the victim in any way. It's to say, okay, if I did this, if I tried to get the person's hands off my neck, that would be one thing. If I, battered them away or did something, are there bruises or other injuries that we have as a result of trying to defend ourselves from the person who's causing them harm? What did the person think was going to happen? Now, most people will tell us they thought they were going to die. It's a very frightening event. Did the person say anything to them? What are they having, any difficulty with anything now? So things like swallowing, speaking, breathing, have they been vomiting? And did anything else happen, like a sexual assault? And of course, the issue related to children. So we do a medical examination. We actually want to know what's happened. We do an examination sort of top to toe when people present to us for sexual assaults, and we will do an examination of the neck, and we'll ask a lot of questions about that. Sometimes people in the emergency departments aren't as familiar as we are with this problem, and so we will go over the questions and double check what might have been dealt with in ED. Most things like petechiae will disappear in 48 to 72 hours. So if somebody comes in and says this happened, today's Tuesday, on Sunday, we may or may not see things. We also might, if that happened on Sunday, not see much on Sunday, and then by Monday we may see some bruising occurring, because sometimes bruises take a little while to just appear on the skin. But often there are no signs to be found, and often if there are, they're so subtle that there's no point in taking photographs of them. If it's less than 12 hours and the person isn't known to them, we're particularly interested in doing a skin swab to look for DNA. But DNA disappears. In household contexts, there's often going to be DNA randomly there anyway, because you're exposed to it in the house. And it's not something we can detect for terribly long as a skin-related issue. So if we look at what might be going on for them, if we have any medical concerns as a forensic person, we're going to refer back to the ED. So I'm not doing, cervical spine stabilization and administering the anticoagulants, but these are just some of the principles of what might need to happen. And they need to have their oxygen levels done. So we're probably now familiar with pulse oximeters after COVID. Everybody knows those little things you stick on your finger to see what your oxygen level is. And they might need other tests done. So some of the tests that we might do are things like medical imaging. X-rays are not as useful, and sometimes we do tests depending on what we want to look at. So if we're looking for emphysema, we might do a soft tissue studies around the neck to see if there's a fractured larynx and the air's leaking out. Oops. Next one. MRI can be used. Very noisy thing, an MRI. I don't know if you've ever experienced any of those, but it's useful for some of the anoxic injuries. And this is pictures of some of the hemorrhaging that can occur into the muscles. Then CT angiography is the sort of classic test that we would do if we think somebody's been strangled, to look for neck dissection. And if you look at this, you can see there are distinct sort of breaks in the, it should be just a nice straight line, and it's not a nice straight line. It's got little gaps in it. So that's not helpful for your brain if you don't have enough oxygen going up your carotid artery to your brain. So CT angiogram is the gold standard for looking at carotid artery dissections. We don't do CT angiograms on everyone who presents with strangulation, because all the forms of imaging that we have, people are being exposed to irradiation. So we have to make sure that we're not causing harm to people who don't need to have a test. So one of the rules of thumb for doing those things is if there are neurological symptoms that people have, yes, we'll do an angiogram. And we don't commonly find something, but we will do tests in case when they're symptomatic. If somebody says they've been strangled and have no symptoms at all from that, doesn't mean they haven't been strangled. It just means that we're less likely to need an angiogram. So we make decisions as we go along. And then some of the delayed respiratory things I mentioned before, aspiration, where people might get something into the lungs. And then laryngeal edema, which is swelling of the neck, so everything gets squashed and you can't breathe properly because of that. There are lots of long-term sequelae for people's brain function. So they can be very anxious, of course, because this is a life-threatening event. They may have things like psychosis occur. Psychosis is where your brain doesn't really work the way it ought to, where people get overstimulated, and it can occur as a result of many things. It can occur relating to drugs. It can occur relating to brain problems like schizophrenia, and it can occur as a result of being hypoxic. So there are a lot of things that can occur, other brain injuries as well. So when people have head trauma in motor vehicle accidents, sometimes there are parts of the brain affected as a long-term problem. Dementia, there's a greater, now some of you will have been reading about footballers, and there's been a greater interest in the last probably 5 years, been interest in footballers and the issue for footballers of chronic brain injury. So all those, particularly rugby, where people go dying, their brains are, there's those, you see them and they now get sent off the field. A long time, I don't know how long that's been going on, maybe 5 years. Previously, it was a sort of manly thing to go, oh yeah, I'm a bit concussed. No, I'm fine. I'll stagger back on the field. We now know that actually people should have time to recover from brain injury, and they should not be out there playing and getting another head knock. And sometimes it's deliberate. People sort of knock into people, but on other times they're just sort of both going for the ball or doing whatever they're doing. It's not a game I play, so sorry, I don't know the details. But you certainly hear about people being, fined for deliberately causing a hit where they smash into someone's head, and the person drops to the ground and really doesn't feel well and is quite dazed, and they should not be playing for a number of days or weeks afterwards, depending on what's happened. They can get amnesia, which means they can't remember things, depressed, suicidal as a result of all of the things happening for them, and then have PTSD, which is post-traumatic stress disorder. So there are a lot of things that can occur for people as a result of hypoxia. And clever neurological imaging people can actually demonstrate some effects of change. And there's so many things going on these days in imaging and in other technical ways of looking at people's bodies and what's happening where. I'm sure over time we're going to get even more information about exactly what's going on in different parts of the brain as a result of some of these things. But because there was a start in the field of footballers, and people have donated their brains after they've died, we're now a bit more aware of chronic brain injury and head trauma, which includes hypoxia related to strangulation. And we hopefully will be getting a bit more awareness of the problem of strangulation, non-fatal strangulation. So there are some other neurological things that can occur. People can have damage to the vocal cords, which is the Neville Rand scenario. Memory loss, not because of strangulation, but when your nerve is affected. You can have seizures. You have strokes in younger people. We don't expect to see strokes. We do see strokes sometimes for other reasons. So some are related to people taking hormonal contraception. That's an uncommon event, but can occur. Brain injury causing encephalopathy. So the brain swells, and then the head, as you know, the skull, very, very, dense and tight and doesn't move around piece of anatomy. So just bone that holds everything in means that if it's swelling, where does it go? It gets squashed because you can't, if your arm swells, if you've ever had even something like something's bitten you and you see the swelling goes up and then it goes down. But if it's sitting on your arm because the mosquito's bitten you, then it just isn't taking up much room. If you've had a fracture, one of the reasons, fractured arm, a lot of people have fractured arms at one stage or another, you have a back slab for a period of time rather than having a full cast. And that's because in the very first days after a fracture, it swells a lot around it. And so you put the back slab on and then you just tape it around, bandage it around, and then you let the swelling get to the point where it's okay, settle down, it's not continuing, and then you put the back slab on. If you put a back slab on immediately, there'd be nowhere. Sorry, if you put a whole cast, a whole plaster or fiberglass cast on, there'd be nowhere for the swelling to go, and the arm would be compressed because the swelling can't break out of that cast. The same with your brain, except that we obviously can't put a back slab on your brain. So sometimes, we have to do all sorts of things to help people to rest their brains. Children, 50% of cases in domestic and family violence settings do have children present, and boys who've been physically abused are a lot more likely to become violent offenders. And young boys who've witnessed domestic violence are even more likely to become violent offenders. So it is a problem, and it is something we really need to try and reduce. One of the problems that occurs for courts and people who go to court, the legal profession, I'm sure, and the police, get very frustrated by people recanting. So recanting is where you come along, you tell your story, and then you go, oh, no, that's not what happened. No, he's fine. It's all, I made it up. People will recant. They might make things up. Certainly, I do meet people who are not telling me the truth. I'm not, not unfamiliar with people not telling the truth. However, recanting in these situations is commonly related to other things, mostly fear of retaliation, emotional dependence, financial dependence. People in DFE relationships often have no independence of their own. The money's all managed by somebody else. They're followed around everywhere. They have now people embed things in phones, and it's extremely problematic. So people will recant. They are not necessarily safer going home. However, we know that one of the most unsafe times for people who are in a domestic and family violence relationship is when they're leaving. So the community thinks, well, why doesn't she just leave? There are many reasons. She doesn't have anywhere to go. Housing, as you know, it's all over the news all the time at the moment with the election. Housing is extremely problematic. There are multiple numbers of people wanting any bed in a refuge. There are insufficient numbers of beds for people to escape to. People often don't have their own finances. So what are they going to do? How are they going to provide rent? So there are lots of reasons why people can't leave. Sometimes people, we try to have a way to plan to be able to leave. But if all your finances are controlled, it's really difficult to do that. So what do people need to know? We like to educate the police and other people, and police are first line often. We want people to know about the imminent risk of death for the victim, the lethality of this issue. There's an escalation of risk associated with a number of times or what's going on. And has the person had a potentially lethal neck injury? So when we might talk to a person to try and assess some of that, these are some of the things that we might look at and that police, for instance, could look at in terms of, has your partner ever used or threatened to use a weapon against you, threatened to kill you or your pets or your children. Killing pets is a first start, because it demonstrates to people, yes, you're willing to kill. So if I can kill your pet, I could kill your child. And we're all familiar again with the number of cases that have been in the media where somebody can't have access to their children, so they kill their children and their partner, and then sometimes themselves. Is the partner jealous? Are they following you? Do you feel it's escalating? Have you ever tried to leave? Pregnancy is another high-risk situation. So pregnancy is actually wonderful if you really want it, but pregnancy in a stressful relationship adds another stress, and it's a dangerous time for women in domestic and family violence situations. Is your partner unemployed? The risk there is they're at home more, they're not doing something, their self-esteem is affected by their lack of employment. Doesn't mean that people who are employed can't be strangulating other people. They definitely can, strangling. And are you being monitored? These are some of the danger, the escalation in danger. We are so fortunate in Australia that we don't have ready access to guns, but we have ready access to knives, and we do have, people do have access to guns, and people are killed, as you know from the early slides, by being shot at times. So early things are things like slapping and pushing, and there's no long-lasting thing. If you slap someone, you might see a red mark for a period of time, but it fades rapidly. Punching, kicking, bruising, cutting, there can be continuing pain, and then being severely bruised and having broken limbs, broken bones, burns, so people still do cigarette burns at times, and then threats to use a weapon. And weapons, of course, be things like a baseball bat or a gun. There are multiple, and a knife. There are multiple ways people have used weapons. And some of the things we look at in injury, if you've grasped a knife, you'll have a defense wound from that. If you put your arm out to try and stop somebody hitting you, then you may get injuries along here, because most of us don't want our face or our chest to be affected. So we might put an arm out to and injure the arm in preference to injuring the chest or the face. Or have they used a weapon? Or have you had an injury as a result of a weapon? And if there's one question that we would want people to be asking to someone if we're concerned about strangulation, it would be, was there any pressure applied to your neck by any means? So we try and distill things down to make it as easy as possible for people. We ask a lot of things, but the one thing that might give us some answers, give us a starting point to know where to go from, or to refer to people like us, is that question: have you had pressure applied to your neck? And I think that's the last slide.
Well, Professor Brown, that was really very interesting and insightful. I actually have a question that came from someone who was unable to attend today, and you sort of touched on it, and it was to do with the fact that when a person is hypoxic, they can't lay down a memory because you need oxygen to make your brain work to be able to remember things that happened. So in a legal matter where a person is alleging, for example, a sexual or other type of assault, where they remember somebody doing that and then they don't remember, how does the medical profession help the legal profession to be able to progress that claim when the person can't remember the assault, but clearly the evidence afterwards shows that there was an assault, and the perpetrator denies the assault, saying they're making it up, they can't remember it, they're making it up?
So just because you can't remember, of course, doesn't mean you're making it up. You might be, but it doesn't mean you are. So it would depend on, there's a whole lot of circumstances that can be associated with not remembering. Some are that people are affected by drugs and alcohol, which may affect you as well. You have to look at, was there any other head injury? And if they're strangled, did they lose consciousness? Because if they've lost consciousness, if they said, I was in and out of it. So that's a term people say when they mean they're not really fully conscious. That we are all, hopefully, sorry about those people online, I'm sure you're all very conscious right now. If you've fallen asleep, I'm not doing my job. But we're all conscious. We know what we're doing. We're entering into an educational session. We're concentrating on that. And we could say, in a few hours' time, well, at lunchtime, I did this interesting or otherwise educational activity online, and this is what I learned. But if you are intoxicated, or if you are hypoxic, you might see things, but you're not clearly functioning like we are now. And so when I'm writing, if I was writing, I do write reports about strangulation. And if I'm writing a report, I will look at all of the factors around that. So I'll look at the police report, the victim's statements, any information that I'm provided with, other health problems the person may have, medications they're taking. All sorts of things can affect people's ability to coherently state what has occurred. And sometimes one of the things we try to do is be minimalist in some of the things we write down, for instance. So if somebody comes on and they said they were at the Harp Hotel on Crown Street, oh, I don't think that's on Crown Street. That's so for us, we'd say, I went to a hotel and I met some people. We'd document, the person told me I went to a hotel. It's not important to us which hotel they're at. And they might tomorrow remember, actually, it wasn't the Harp, it was the Illawarra, which is on Crown Street. So, or, whatever, that there are things that affect people's memory. They sort of went, oh no, they change. And so we try to have pieces of information that are less open to change when we're looking at things. And the police investigations for things will look at things that might change, or their statements might be more specific to the actual location. We're not that interested in some of those things. But the person may not remember where it occurred. They say, I went out and I was at a nightclub, I don't remember what it's called, and I had a couple of drinks, and I don't usually get drunk on 2 drinks. Now, a couple of drinks for some people is, we know people drink too much as well. So sometimes they might have had a lot more than a couple of drinks, but we can do toxicology for those things. They might be at home though in these situations, and they say, I was home with the kids and we just had dinner, and he came home and he got really angry and he put his hands around my neck, and the next thing I'm on the floor. And then she wakes up and she's covered in bruises and she has no idea how any of that happened. And her story is she was doing her regular routine, and somebody known to her usually, came along and did something to her, and she woke up. So if you lose consciousness, you can't know what happened. You cannot say, this is what happened, because you're unconscious. The same as when you're asleep. If you were asleep, you can't say exactly what's happening around you because you're asleep. It's different from sleep, but it's that principle of you're not engaged in the situation. And if you're fearful and you're hypoxic and your brain's just not getting the right messages, neurologists will be able to tell you in great detail exactly how these memories occur. There's a lot of research on memory, and I'm not a memory specialist, but the principle of it is that people cannot, if they're not making the memory, it does not necessarily, it's the same as lack of injury, does not necessarily imply that an event of whatever sort, in a sexual assault, for instance, or a strangulation, it doesn't mean. So you have to look at a lot of it's looking at the whole situation, it's not only pinning it on this one thing that will determine yes or no. Does that make sense?
Right. Yeah, no, that's good. That's good. Does anyone else have any questions they would like to ask? No, and usually that's when the presentation is very comprehensive, which this was. Associate Professor Katherine Brown, we thank you so much for your time today and for sharing your expertise with us. It was indeed very, very insightful. And as you say, there is no such thing as safe strangling, and we really need to get that message out, not only within the legal and personal injury community, but in the community generally. We cannot have people thinking that this is a normal practice in any way. I thank you again. Thank you, everybody, for joining us, and we'll see you at the next free MAG educational seminar.
Thank you very much.